Today I will talk about an important part of clinical evaluation skills, which is related to history taking skills. We all know that for clinical evaluation of any patient, we have to carry three important steps, which are consecutively number one, history taking, or the patient's interview, and then physical examination, or what we call the bedside examination or the clinical examination, and then the asking for clinical investigations, including laboratory investigations, radiological investigations, pathological investigations, etc., etc., all investigations. So number one is history taking. And the history taking, of course, is a very important component of the clinical evaluation of the patient, because from the patient's history we can get the symptoms of the underlying disease, which are subjective findings mentioned by the patient. And sometimes we can reach to the diagnosis from just asking the patient about the details of his symptoms in the history or during history taking from your patient or your case. Sometimes we can reach only to the diagnosis from the history. As I mentioned before, to diagnose cases of bronchial asthma, for example, we can just reach to the diagnosis of bronchial asthma, which is a chest disease, from analyzing the symptoms, the exact symptoms of chest disease, like cough, like chest wheezes, like these things, which are intermittent, and so on, so on, so. Also, migraine, we can get the detailed descriptive symptoms or the descriptive features of the migrainous attacks from the history. Or another example, angina. Angina pectoris, which is a chronic form of ischemic heart disease. We can also get the diagnosis from the detailed descriptive features and the details of the ischemic cardiac chest pain given by the patient during history taking, and etc., etc., etc. There are many diseases which can be diagnosed from the history, especially that on physical examination there may be no detectable physical signs on bedside examination. Although, as I mentioned before, in most of the diseases we reach to the definite diagnosis or the final diagnosis. We can reach it, or at least differential diagnosis or differentials, from carrying both steps of history taking and physical examination together, important in order to get the symptoms, the clinical symptoms and the clinical signs which can point to possible diagnosis, whether it is differential or it is definite final diagnosis from the beginning. But in many cases we can reach the final diagnosis with time, and with the third step of asking for clinical investigations. After the clinical investigations, we can reach from the three together, the history, the physical examination, and the clinical investigations done, we can reach to the definite or the final diagnosis. But as I mentioned, the history taking is important in diagnosis of many, I will not say some, but many diseases can be diagnosed from the symptoms. And I gave examples already of these diseases. So the history taking needs also special skills, and this is what we call the history taking skills, which starts with asking the patient about his presentation or presenting symptoms or complaint. What is he complaining or she is complaining of, and then after that analyzing the what we call the history of present illness. By analyzing the presenting symptoms, we have to ask for the onset, course, and duration of every symptom, and any associated symptoms which are important and relevant to the case, and the important positive symptoms, and also the important negative symptoms. And an important issue here in the history taking is that we should not ask the patient leading questions. We should, when we ask the patient during this history taking, we have to ask indirect questions. This is the basic rule. Exceptionally, we can ask the patient in some cases, under some conditions, more direct questions. But to start with, the basic is to ask indirect questions and not asking direct questions, except occasionally and exceptionally in some cases under certain circumstances or conditions, clinical conditions. So this is an important rule, is don't ask leading questions. Don't ask your patient leading questions while you are asking about the clinical symptoms during history taking. Also, in this part of the clinical evaluation, we should listen. Here, the three general basic clinical skills which I mentioned before, that is the listening and thinking and observation, should be used during this step of history taking. We should learn how to listen. We cannot get what the patient suffering from unless we listen to him. We should have what we call active effective listening, and we should not interrupt the patient unless we will direct to him or give him or her the question and then listen while the patient's answering. We have to listen, we have to be patient, we have not to interrupt the patient while he is mentioning his real problems or analyzing his symptoms, which are different from case to case depending on the presenting symptom or the presenting complaint or complaints of the patient. So here listening is very important. We should start to think actively also during this stage. While the patient is talking, we think about what we have got, and we should also observe his faces. We should observe his look. We should observe his reactions during, which might point to a specific clinical problem. Also during is there is any pain on his face, or is there any restlessness or any irritability like in thyrotoxic patients. So actually observation and the examination, at least of the general look or the general appearance, might start during history taking before we proceed to do it in reality on physical examination or the bedside examination. But we should start actually doing the examination by observing the patient face, the patient look, the patient attitude, and the patient posture during history taking. So actually listening, thinking, and observation, which are basic general clinical skills, start during, we use them during while we listen to the patient on history taking. And this is very important to remember. That's carrying the listening. You have to listen, you have to start the implementing and putting into practice the skill of listening to your case, starting from the physical examination step, of the history taking step. So this is very important. We should also ask about any associated symptoms relevant to the case. For example, if the patient presents as a chest case presented with a chest symptom like cough, after analyzing the cough, the type of cough, the severity of cough, the duration of cough, is it intermittent or persistent cough, is it productive or dry, is there any blood in the with cough, that's hemoptysis or not. After analyzing the cough as a symptom, for example, in patient presenting with this important chest symptom, we should ask about other chest symptoms like dyspnea, like chest pain, like chest wheezes. All these are other more general symptoms in the body related to other systems of the body, might be important and relevant to the case. This is what we call analysis of the presenting symptoms and whether there is any associated symptoms or not, and ask about the important positive symptoms and also asking about the important negative symptoms. For example, important negative in a patient presenting with cough, that's it's important to exclude the presence of blood-tinged sputum or bloody cough, that's hemoptysis. So hemoptysis is an important negative, at least for example, to exclude pulmonary tuberculosis or bronchial cancer, because these are important two causes of hemoptysis or bloody cough or bloody sputum. So this is important negative in cases presenting with cough. Also important negatives, chest wheezes, if we are suspecting, for example, bronchial asthma or chronic cough and sputum, if suspect case of chronic bronchitis in a chronic obstructive pulmonary disease, or chronic dyspnea in patients who have emphysema, etc., etc. So these are important negatives we have to ask the patient, as well as the important positive symptoms related to the presenting symptom, as I mentioned. Also, this is in the history of present illness, and sometimes we have to go outside the involved organ or the involved system. For example, if the patient presenting with a cough, which is a chest symptom or a symptom of respiratory disease, we have to ask about extra thoracic manifestations related to the heart, related to the liver, related to especially in possible systemic diseases which involve more than one organ, for example, involving the heart and the chest, or involving the chest and the liver, or the chest and the kidneys in systemic diseases, or multi-systemic diseases which are involving more than one system or one organ in the body, and this might happen in some clinical cases. So here the broad spectrum mind of the physician, and using what we call high index of clinical suspicion, if the clinical condition or the clinical situation mandates the clinician to ask about and to go further asking about other symptoms related to other organs or other systems in the body. So this is very important in the history taking. Also asking about the past illness, the medical history, any previous similar symptoms, or any history of similar attacks or similar complaints. This is past history. Any medical surgical history, any operations before, because the key might be in the asking about surgical history. For example, in patients presenting with abdominal pain who have done surgery before, might be the current pain related to adhesive intestinal obstruction due to the previous surgery. So here, for example, is an example of importance of asking about surgical history. Also asking about the history of special habits like alcoholism, if we are dealing with a case suspicious of having alcoholic liver disease, for example, or alcoholic heart disease, or diseases of the brain related to chronic alcoholism. So we should ask about alcohol. We should ask about smoking in chest diseases, and in suspicious also heart disease, because we know smoking is a risk factor for many diseases related to the chest and to the heart, and even to the esophagus, to the stomach, to the other organs of the body. So asking about smoking is very important, and the type of smoking and the duration of smoking, and all of these things important in history of special habits. Asking about sexual history are important also in patients especially presenting with what we call sexually transmitted diseases or venereal diseases, which are related to the sexual life and the sexual practice of the patient. So asking about sexual history might be important, a very important and essential part of the history taking in sexually transmitted diseases, or if you are suspecting your case to have a sexually transmitted disease or a venereal disease. Also asking about, in addition to the social history and special habits, and to the past history, and to the surgical history, and to the sexual history, also occupational history in occupational diseases like occupational lung diseases, the cases of allergic alveolitis, or also hypersensitivity pneumonitis in special occupations. So occupational history might also be important, especially in occupational diseases. So asking about the occupation of the patient, which might, and in cases of asbestosis, silicosis, bird fancier's disease, mushroom lung disease in farmers. So many diseases are related to occupation, and this should be triggered and asked for depending also on the case and the clinical situation you are facing and the clinical case you are facing now. So this is occupational history. Also asking about, as I mentioned, the sexual history is very important. Asking about the drug history is very important, because we have a very broad spectrum of diseases called drug-induced diseases. We cannot reach to the nature of this disease. For example, drug-induced lung disease, drug-induced heart disease, drug-induced liver disease, drug-induced kidney disease, drug-induced bone marrow disease or hematological disease, drug-induced CNS disorder, drug-induced neurological disorders, drug-induced neuropathy, drug-induced immune disruption, even drug-induced cancer. So we will not reach to this type of diseases unless we ask about any history of drugs taken for a long time, and the duration of drug use, and the doses of drugs used. And the most common, for example, are steroids, corticosteroids, which are related to diabetes, which are related to osteoporosis, which are related to hypertension, which are related to many problems in the body. So there are specific drug groups which we should ask about, like antibiotics, like analgesics, like corticosteroids, which commonly cause drug-induced organ damage. So drug history is important in many cases, and we should always ask any patient about drug history, especially in patients presenting with chronic recurrent problems. So all of these questions we should ask about, and we should be aware about, and we should focus on during history taking, and this is part of the history taking skills, and the skilled physician should know how to take and to gather as much information as possible in the shortest duration of time, regardless of whatever the doctor is under a stressful situation or in a busy clinical atmosphere, how he can get the effective, how he can carry on an effective history taking within the shortest time available, in order to finish the case in a busy environment or in a busy clinical atmosphere, without having drawback of ineffective history taking or shortage of information got from the history, which will be reflected at the end on the clinical conclusion, because the physician didn't do the history taking part of clinical evaluation effectively and professionally and skillfully. So here is the importance of the what questions you have to get, and during the shortest possible time, and with adequate listening, effective listening, active effective listening to your patient, and without interruption of the patient's talk, and with the clinician completely patient with his case, in order to give him the time or give her the time to explain his problem, and to express at the same time empathy and sympathy with the case, and especially that in many cases the diagnosis can be reached from only or especially in these clinical situations or in the diseases in which you can get the diagnosis from listening to the patient on history taking, as I mentioned before. Today I will finish my this mini lecture about history taking skills, effective history taking, and its relevance to clinical evaluation. And tomorrow I will continue talking about the next step, which is physical examination skills. Thank you so much. Have a nice day.